So the topic that I'd like to share today is a topic that's very, very intriguing to me. And I first became kind of intrigued about laser or low light therapy or photobiomodulation, all of the things that it's called these days, back in 2012 when I first started working at the Carrick Institute's clinic in Atlanta. I had a patient who was in for a concussion, and just in speaking, she said that, you know what, I don't know if you guys can help me with this, but I've got a really bad wart on my toe that will never go away. I've been trying for years and years and years, frozen, medications, everything. They needled it, they abrased it. Nothing made it go away. So at that point, we had a pretty high-power laser, and I just said, you know what, there seems to be a lot of talk about this for dermal conditions, so let's try it. So what we did is we applied that laser to her second toe 3 times a day for about 3 minutes. At the end of the week, the wart became really red. 2 weeks later, she said it was completely gone, and I've spoken with her since then, and she said it's never come back. So at that point, my curiosity was piqued, and I said, there has to be something to this type of therapy, but how do we apply it in a practice for neurology? Because I'm not in the business, neither are you, for treating warts, but we treat brains, so let's figure out how we can apply this to the brain. But at that time, everybody was saying, you can't penetrate the skull. Light doesn't go through the skull, you know, there's no way that you can target the brain. And from there, I kind of let it go to the wayside until a couple years ago when I became interested in it from an article that I read. And I want to share just a little bit about my interest and my team's interest in photobiomodulation. So we're going to talk about shining light on TBI, applications of transcranial low-level therapy. So at our facility, we do this. Some of the things that we're going to talk about today are things that we actually do in clinical practice. So here you see somebody is doing transcranial photobiomodulation with non-invasive neuromodulation for post-concussive syndrome, one of the different types of therapies that we were doing with this one gentleman. Here's a woman that's doing transcranial photobiomodulation with a visual evoked potential, as well as some non-invasive neuromodulation for her post-concussive dysautonomia. So these are things that we're doing in applications, and many of us have lots of questions around this. Most of all, how can light aid the recovery of brain injuries? So what our objectives are today, we have 7 objectives. One of them is to review the history of photobiomodulation so we can see where this practice is evolving from and where it is at the current state. Discuss the cellular physiology of PBM. So whenever I try to, whether I want to implement something into clinical practice, I want to understand it. I don't like to just do things just because other people are doing them. I like to be able to understand why we're doing what we're doing, because if something goes wrong, if you understand the basis of it, you can understand how to fix it, and also you can customize your treatments for your patients. So we're going to talk a little bit about that today. We're going to review a little bit of the literature that actually shows that transcranial light modulation or photobiomodulation is possible. Light can penetrate the skull if you have the right settings. We're going to identify the factors to consider with PBM. We're going to talk about a little bit about calculating dosage. We're also going to discuss potential side effects. And finally, we're going to compare and contrast proposed mechanisms of PBM, photobiomodulation, with the cellular mechanisms of traumatic brain injury to see if there is a feasible solution here or a feasible application of light. So a little bit about the history of photobiomodulation. We won't go through this whole thing, but you see, in the 60s is when laser therapy was really evolved. The first laser ever invented was the ruby laser, was in 1960, and you can see in the decade of the 60s, many people were kind of experimenting with this type of laser. In 1965, Boston, or actually a Harvard scholar, destroyed cancerous tumors in a rat using laser therapy. And then Dr. Mester tried to reproduce the experiment, didn't have the same results, but what he noticed is that the rats that he was treating actually grew hair back on the scar tissue where they had done some incisions. Later, they found out the reason why it didn't help the tumors, but it helped the skin, the hair regrow, is because his laser wasn't strong enough. So he discovered low-level light therapy almost by accident. Later on, we start seeing that there's some studies that are, once again, supported by Mester and his colleagues on human healing and hair growth. We looked at adding infrared to the photobiomodulation spectrum all the way in the mid-70s. And then from there, Carrick identified the target of photobiomodulation that we exist today, which is cytochrome C oxidase, which we'll talk about in just a minute, which is part of the mitochondrial or the electron transport chain. In the year 2009, there were some studies published about photobiomodulation for stroke. Now, this began getting people thinking, wait, how can you treat stroke if light doesn't penetrate the skull? And there was a feverish investigation about can light penetrate the skull. So in 2015, Jadego, who we're going to talk a little bit about a little bit later, discovered that light can actually penetrate the skull, and we're going to talk about how deep it actually can penetrate the skull. And then a little bit later, in 2016, which is not so long ago, the whole terminology is beginning to evolve. Laser, low-level light therapy, we kind of started clustering them all together into photobiomodulation because the spectrum goes all the way from 1 milliwatt all the way into multiple watt lasers. So it's not necessarily low-level light therapy as a treatment modality. So that's kind of where we are today. Now, to understand how light can actually affect cellular physiology, we have to dive into a little bit of a cellular mechanism. And there's something called a chromophore that exists inside of most species, bacteria included, most eukaryotes. And what chromophores do is they are actually specialized portions of the cell that are responsible for absorbing photons. So light is packets of photons, and we have to have some way to biologically accept those things. And we know of a couple really common ones. If we all think about it, melanin, right? In our skin, melanin is a chromophore. So when ultraviolet lights hits our melanin, we have a chemical reaction that comes that creates pigmentation, and we start tanning. So this does exist. It also exists in plants. Chlorophyll. Chlorophyll is a type of chromophore as well. It accepts sunlight and creates a cellular mechanism inside of that plant. Well, there's two different types of chromophores. You have specialized and non-specialized. The specialized ones you're using right now, which we have rods and cones inside of our eyes and allow us to accept photons. And you see down there in the middle, we have three different types of cones in our eyes, right? We have reds, we have greens, we have blues, and that allows us to see the visual spectrum. What's interesting is these chromophores either absorb or reflect different wavelengths of light. So at the bottom, we see that the red chromophore in our cones accepts lights at 560 nanometers, and it rejects or reflects everything else so that we can see red when those chromophores are stimulated. Green, 530, blue, 430. So we see the number starts to decrease as we go towards the blue end of the spectrum or the ultraviolet end of the spectrum, and the numbers start to get higher as far as the wavelengths as we go towards the infrared or microwave. Now, speaking of microwaves, a microwave is just a continuation of the electromagnetic spectrum, right? And one of the things that we see with microwaves is anytime you put a piece of food in the microwave, what happens to the food as you turn it on? It heats. Does it heat on the outside? No, it heats all the way through, even if it's in a container. So microwaves can penetrate different types of aspects. So when we start moving a little bit farther up that spectrum towards the ultraviolet spectrum, we should also assume that those wavelengths that are longer can also penetrate like microwaves can. So that's something we should start thinking in the back of our mind. So we also start to see in the right side of the screen, we have some of the different cells that are in our eyes. Some of them are photoacceptors, which are the types that don't have any participation in senses. And we have photoreceptors, right? So photoreceptors talk about phototransduction. And when we start looking at receptor-based therapies, we always say that receptors have one job. They're transducers. They take some sort of a physical energy, and they convert it into electrical energy so that we can experience the world in which we exist. So the phototransduction occurs in the receptors, and then the photobiomodulation occurs in the photoacceptors. Receptors versus acceptors, okay? So when we start really getting into this electron transport chain, there is a target of photobiomodulation, and this is cytochrome C oxidase. So cytochrome C oxidase, when we start looking at the electron transport chain, has a really, really important role in mitochondrial function. It's the last stage in reduction in the mitochondrial electron transport chain before we can produce ATP. So when we say when light hits cytochrome C oxidase, what it does is it implements the complex 4 of the mitochondrial transport chain, and what that does is that takes hydrogen molecules, and also when we start looking at O2 molecules, which are superoxide molecules, and that converts it into water. And when it converts that into water inside the mitochondrial matrix, what it does is it releases hydrogen protons into the extracellular space. Well, when we start looking at it, that's the first thing that happens is when light shines on this cytochrome C oxidase, it creates hydrogen molecules. And as those hydrogen molecules start to increase in their numbers, we can see there's an influx into complex 5, which the end result is ATP. We all know that ATP is super important for what? Life, for energy. However, we also know that free hydrogen molecules are not also the best thing for us either. So in an electron transport chain, we're going to see that there's going to be a release of nitric oxide, which, as Dr. J was just talking about, is really important for vasoconstriction and dilation regulation, or vasoregulation, I should say. But we also know that nitric oxide can have detrimental effects on cellular function as well, too, because it can actually block cytochrome C oxidase. So some of the research thinks the reason why we have this sharp drop-off curve or this hormetic curve with laser therapy or photomodulation is because you may exceed the metabolic capacity of the mitochondria, which is a term that we've been talking about for quite a while. The other thing that happens is we also have an elevation of temperature. And elevation of temperature is anything on the realm of 1/10 of 1 degree Celsius has a big change in intracellular pressure. So you start having more changes in sodium, potassium transduction, and things of that nature. We also know that some of our cells have thermoreceptors or temperature-gated channels that can allow influx or outflux of ions. So those are the primary effects of this photobiomodulation. When we start looking at secondary effects, there's many, many, many. And there's a little bit of a diagram on the side there, and you can kind of go through that. But realistically, what ends up happening is protein kinases become set into place, which kind of create the release of calcium and cyclic AMP, which are signaling molecules. And nitric oxide, as well as the reactive oxygen species that are produced by the electron transport chain, are cellular molecules that signal for cellular processes to occur. Everything from immune activation with some of the reactive oxygen species. We start activating superoxide dismutase, which is a really strong antioxidant that promotes cellular health. But we also see that the secondary messengers also activate different types of metabolic pathways, not on a mitochondrial layer, but on a nuclear layer, such as transcription, translation, and protein production for cellular health. But there's also tertiary effects of photobiomodulation. And we see here in the bottom right-hand corner, this is from a paper published by Hamblin. And right now, from what I've been able to read, Hamblin seems to be one of the authorities in this area. One of our colleagues here today has a great poster presentation that he did with Hamblin. And Dr. Hamblin works at Mass General Hospital, Harvard trained, and they have a whole department on photobiomodulation there at Harvard. And he's one of the main people in charge of this. And what he found is that the tertiary responses to photobiomodulation mean that you increase more blood vascularization, angiogenesis, synaptogenesis, which is a huge interest to us, right? We talked about superoxide dismutase upregulation, NF-kappa beta, or a big anti-inflammatory cytokine gets produced. We have upregulation of mesenchymal stem cells, which can differentiate into neural tissue. They can be created into fibroblasts for collagen and muscle and muscle tissue, Lots of changes that happen. We have increased lymphatic drainage. Then we get the dissociation of nitric oxide. So we produce it, then we dissociate it, so it's not such a harmful chemical, because at certain points, concentrations of nitric oxide can also change membrane potentials. We also see increased blood flow. So you see there's primary, secondary, and tertiary, and then there are systemic effects. So before I talk about the systemic effects, there was a great study that was published by Johnstone down in 2014, and they were kind of a little bit skeptical about this transcranial stimulation. So what they did is they took a bunch of rodents, MTPT rodents, so these are people that they genetically and experimentally induced Parkinson's disease with. And what they did, and I couldn't find a good picture of it, they put tinfoil hats on the rats, almost like the people from outer space are coming for them, right? So they put tinfoil hats on them so that the light cannot penetrate the tinfoil and affect their brain, but they shine the light on their body. And what they realized in their controlled study is that the ones that had the lights that shined on their brain had the best results with some of their task speed and walking speed and maze test. But the ones that had their head covered with aluminum foil also had significant improvements over the controls. So this leads a little more to question, right? What are the systemic effects of photobiomodulation at ulterior sites? And the place where they actually shone the light on these rodents was actually on the tibia. So they shined it on their tibia. It wasn't on their spinal cord. It wasn't anywhere in the nervous system. It was on their actual tibia. So some of the effects of photobiomodulation cannot be explained entirely by photons penetrating the skull and accessing brain tissue. However, what they have shown is that in 2003, the calvarial bone has really high levels of mesenchymal stem cells that exist inside there. So maybe there is some photoactivation of mesenchymal stem cells. And they also showed in 2011 with Ando that the effects can last days to weeks and potentially even months after the stimulation stops. So there are systemic long-term effects that happen there. Now, when we start looking at light, there's a lot to understand about light. And the most complex part, and this is what's kind of gets overshadowed by the ease of application, is the complexity of light. And what I mean by that, it seems pretty easy to go beep, right? Wait 10 minutes and then something happens. But the complexity of it, the richness of it is really understood in its complexity. So whenever we have photons that hit matter, and we'll call this matter tissue at this point in time, there's a couple things that happen. The first thing that could potentially happen is the light is reflected. And this is what you see when you shine laser. So anything that you see when you're doing laser or photobiomodulation is energy that's not getting into the tissue. If it was getting absorbed into the tissue, you wouldn't, what? See it, because 100% is getting absorbed. So the first thing we look at is reflection. As it starts penetrating and transmits through the surface, one of the other things you'll have is refraction. So you think you're pointing it there, but just like with X-ray, it can scatter and go in a different direction. An important part of refraction is internal reflection. So you can see that that reflects at a 90-degree angle to the vector, and what does it go back towards? Your target tissue. So we actually use some of this scatter when we're looking at photobiomodulation. Other things that we have on the right side of the screen there is you see diffraction and scatter. This is energy that becomes wasted or absorbed by other tissue other than your target tissue. And then we also have backscatter. So when these light waves or these photons get in, they just go all over the place, and a small percentage of them go right to where you're trying to target them. So we always have collateral influence on our tissue with photobiomodulation. When you start looking at penetration, only light that is absorbed by the chromophore is actually utilized. So chromophores reflect or absorb certain wavelengths. And what happens with sunlight, because a lot of people say, well, why don't I just stand outside in the sun and I'll get tons of infrared, visible, and UV, is that when you have tons of light, especially non-coherent light, it scatters all over the place and reflects all over the place, and you don't get a concentrated dose of any one wavelength. When focusing on transcranial photobiomodulation, we also have to consider impedance by both hair, by skin, and different colors of skin. Darker skin doesn't transmit light as well as lighter skin. We have to consider the lack of transmission through bone, meninges, blood, bladder, and tissue. Different tissues also have different impedances. As a matter of fact, when you look at gray matter versus white matter, they have totally different impedances for this photic energy. And when you start looking at some of your different devices, wavelength has the greatest impact on penetration, not power. Everybody's always trying to buy a powerful laser. It's not always the right thing, depending on what you're trying to accomplish. So your target tissue should be the determining factor on what type of light you're purchasing or what type of illumination source. But penetrating the skull, it doesn't really happen. So we talked in the beginning about how we were going to come back to Jadego. He used the human cadaver heads with the skull intact as well as soft tissue to measure penetration of 830 nanometer light, and found that the penetration depended on the anatomical region that they were trying to shine the light through. So different skull bones or cranial bones have different transmittance of light. So less than 1% in the temporal region, 2% at the frontal region, 11, almost 12% at the occipital region. And it said specifically in this report that 633 nanometer wavelength had hardly any penetration through the skull at all. Does that mean that 633 or in that spectrum doesn't work for photobiomodulation? No, it doesn't mean that. It just means that maybe your intended target is different than the actual target being treated, and we'll talk about that in just a moment. Tettert in 2015 also used the human cadaver heads and compared penetration between 3 different wavelengths, 660, 808, 940. They found that 808 was the best and can reach a depth of up to 40 to 50 millimeters into the brain tissue. And we start looking at the cerebral cortex. Some layers of the cerebral cortex are only 10 millimeters thick, so you start seeing there's some significant penetration into the brain tissue if you're using the right wavelengths and if you consider the impedance from other tissues. So we know that about 2 to 12% of energy delivered transcranially will actually even reach the cortex. A 20-fold higher efficiency of light is delivered through the sphenoid. So intranasalar, so you'll see some applications of intranasalar light, 20 times more gets through the sphenoid because the sphenoid is not as big. And we know what lives behind that sphenoid and how beautiful and important it is, right? This is where you have structures like your nigra. This is where you have structures like your brainstem and your ocular motor nucleus and all those things that sit right behind there, the thalamus, the basal ganglia, all of these different beautiful areas that allow us to interact with the world. And you have a great pathway right through your nose. We also understand that when considering tissue impedance, it'll really help you understand how to pick your instrument and target your tissue. So let's maybe segue into light sources and dosimetry. Now, dosimetry and light sources, the mechanisms behind photobiomodulation are not so controversial in the literature. People are pretty well understanding how this is working. We've been working and looking at it for over 50 years now. The most controversial aspect is what light do you use and how much do you use it? What are the settings? And what you're going to see in just a few minutes is that it gets pretty complex, and now you've got to go back to grade school and start doing some math, right? And so there's 2 parts of dosimetry. The one is the instrument, the second is the dose. So instrument generates power or irradiance, and this is designated by watts per square centimeter. However, the dose is energy, or also called fluence, which is joules per centimeter squared. So watts per centimeter squared versus joules per centimeter squared. And we're going to talk a little bit about what's the difference between irradiance and fluence. So when you're looking at an instrument, there's 4 factors you want to consider: the wavelength, the power, the coherence, and the pulse structure. So the wavelength is going to tell you what tissue, or you're going to ask yourself, what tissue do you want to treat? The power is going to say, how much tissue do you want to treat? The coherence is going to say, well, should I use a light-emitting diode or should I use a laser? And the pulse structure is important because it's going to help you consider some of your power calculations and your dose calculations. So here's a diagram that I kind of put together for you that really summarizes a lot of what people are talking about right now. I want to draw your attention to the right side of the screen where it goes from the 400 nanometer spectrum all the way down to the 1100, on the left side of the screen, then transition over to the right side of the screen where you're going to see the chromophore that is affected by that specific wavelength. So when we start looking in the 400 to 700 nanometer spectrum, your target tissue is melanin. So when you're in the tanning bed, that's at the higher end, right? That's 400 spectrum, ultraviolet, hemoglobin, and myoglobin. So really, really important if you're looking at superficial types of injuries, when you're looking at tissue repair, when you're looking at aches and pains and blood flow and inflammation. And then there's a gap of what the research is pretty well determined is completely unusable wavelength between 700 and 750 plus or minus about 15 nanometers of light. And it just doesn't seem to be really absorbed by anything, maybe a little bit by melanin and a little bit by hemoglobin, but it doesn't really have a therapeutic consequence. And then from 750 on, our primary chromophore is the cytochrome C oxidase, which is going to give us more ATP, all of those amazing things that we just talked about. And as you go farther down the list there, you start seeing that the major chromophore becomes water. This is why you put something dry in the microwave and you put it on for 5 minutes, and it doesn't do anything. Because as you start going down that spectrum, water seems to be the chromophore, what's absorbing most of that energy. So what that means, if water is the chromophore in those spectrum, there's something we need to be considerate of. And what is that? Heating. Okay, so heat becomes an issue. But we also said that heating can be a good thing because there are heat-gated channels on these cells that allow us to have action potentials, that allow us to create ATP and protein kinases, all of these different things. So, and we also have to look at some of the depth. So let's go across the x-axis where we look at more of the, and it's almost kind of like an XY coordinate system here. When you have those 400, you're looking at dermal. As we go a little bit higher in the wavelengths, we're going to look at more tissue and vascular aspects than bone and joint. Once we cross that threshold, we're looking a little bit more brain as the primary target. And as we go down into the real infrared spectrum, we're looking at deep brain tissue is realistically our target for some of those different wavelengths. And in the top right-hand corner, you can see a good graphical illustration of the difference between a short wavelength and a long wavelength. So you see the penetration of that short wavelength is only about 5 millimeters. When we start looking at the distribution of that long wavelength, you see that there's a whole lot more penetration of the longer wavelength. So power, how much tissue do we want to treat? That's the question we're going to ask ourselves. The power of light used in photoneuromodulation, now we're kind of focusing a little bit more on the neuro side of things, is about 1 milliwatt to 1,000 milliwatts per diode. Okay, so you're looking at about a 1 milliwatt to 1 watt spectrum. Outside of these thresholds, the light is either too weak to have any effect or so strong that harmful effects may actually outweigh the benefits, and this is from Chung in 2012. Power and time are inversely related to dosimetry, so the more power you have, the less time you'll treat for, but less isn't always more, right? Because we're going to talk in a minute about tissue capacitance, so tissue can actually store energy, so maybe longer is better. So, as we just said, higher power isn't always better. Tissue can act as a capacitor and actually stores energy over a period of time. Longer sessions, the same power can provide greater penetration without necessarily heating up the tissue as much. So higher power can produce more heat and causes a sharper hormetic curve. So everybody's familiar with that term hormesis, right? Same thing we see with radiation, X-ray has a hormetic curve. Some of it's beneficial, some of it's detrimental. Light has the same exact curve. And here's a 3D rendering of that hormetic curve. And what you'll see there at the 0.0 seconds with 0 radiance, as you go up that y-axis there, you're going to start seeing that power starts to increase. But look at the shape of the mountain, if you will. Look at the shape of the mountain from one side to the other, and what you'll see is there's a sharp drop-off with the higher power. And then if we look at that bottom right-hand corner, there's almost like a plateau at the top before it starts to drop off. So lower power is actually a little bit more forgiving if the dose calculations aren't actually right. And you'll see in just a moment how tricky it is to do some of these dosage calculations. Right now, the literature pretty well supports that a maximum tissue dosage for photoneuromodulation is about 6 joules per centimeter squared, but the average is about 2.2. So this is not what you're delivering from your instrument. We have to look at the perspective of the tissue we're trying to treat. So we're going to work backwards in calculating some of our dosage. Dose is usually in joules, and a joule is 1 watt per second. That's the calculation of a joule. Here's what you need to be cautious of. When you're looking through your laser catalogs, most of the time, these devices are displaying their power in milliwatts, right? So a milliwatt is 1/1000th of a watt. So which means that when you do that conversion, you're actually looking at 1/1000th of a joule per second. Okay, so we have to make sure we take that into consideration because somebody can say, hey, my device is 2,500 milliwatts, and you say, whoa, that's pretty high, it's 2.5 watts, which is still significant, but just don't get caught up in the numbers. And this is where we kind of deconstruct things and be educated physicians and know what we're trying to accomplish with what we're doing. Coherence was another thing that we were talking about. Coherence is essentially the type of wavelength that you have. So lasers emit monochromatic, meaning one color, coherent wavelengths that are coherent in time and space. So you get this one beam, and that's it. When we start looking at low-level light therapy and things like LEDs, they're non-coherent, but they're also monochromatic. They have one color, but you see there's a bunch of different wavelengths. At the bottom right-hand corner, you see sunlight. It's completely non-coherent, and it's multichromatic, so we have all of these different wavelengths there. And when you start looking at some of the research for Rojas in 2011, he pretty well said that both are effective. However, no non-coherence light seems to be able to affect nervous tissue a little bit better, specifically because you can have lower tissue energy densities with less heating and accomplish the task that you need to with neuromodulation. Pulse structure, another thing that we need to consider. So this can factor into your usable power calculations. So one way to look at this is a duty cycle. So if you have a pulse that's on 50% of the time and off 50% of the time, and they're advertising this is a 1,000 milliwatt light source, what's your usable power? 500 milliwatts, because it's off 50% of the time and on 50% of the time. So a lot of times when we see some of these pulsed lights, we just have to be educated consumers and say, okay, what's your duty cycle? You know, how long is the laser on when I turn it on? But some of the things that we need to really consider in calculations are what's called spectral width. It's just, in camera terminology, it's the aperture, or also with your pupils, it's the aperture. How wide is the actual light? Because the wider it is, the more it's going to affect the surface. And a lot of these calculations are in milliwatts per centimeter squared. So you want to ask them, well, how big is the beam? If you're telling me it's 1,000 watts per millimeter squared, and the light is only a nanometer thick, that's a really what? Low-powered light source. You can see where it starts to get so confusing, right? And what we can do is we can make this presentation available to you for the Carrick Institute. Happy for you guys to have it so you can review it. I think that there was a lot of time put into this, so hopefully it'll be beneficial to you. But we also have to consider peak wattage, pulse width, pulse frequencies, and there's some calculations there, and I'm kind of running a little lower on time than I wanted to, so I'm going to run through some of these things so we can get to the good juicy stuff. However, one thing important on this slide is that pulsed photobiomodulation has been shown to be significantly more effective than constant waves. So a light that's always on is not as effective as pulsed. Now, they think the reason why is that little bit of time, because remember, the mitochondria, it's not like this fast, right? It's a lot faster than any of these lights can actually pulse with. So the thing is that if you have a constant light form, there's not really any time for that intracellular balance to occur and for there to be a rest period in between the stimulation. So any type of pulsation seems to be more effective in the literature than constant. When you start looking at pulse, there's not a whole lot of literature surrounding what frequency the light should pulse at. But there are some people that are getting a little creative here and saying, well, entrainment of wavelengths, of brain waves exists. This is the basis of neuromodulation, right? This is neurofeedback and things like that. We can entrain wavelengths. Well, if energy or electricity can entrain wavelengths, why can't light? If we're penetrating, which we've already established that we are, why can't the flickering of a light or a dose of energy at a certain frequency, why can that not entrain wavelengths? So you can actually maybe use this as a prescription cookbook for things that you're trying to target. So delta waves, looking at half hertz to 3 hertz associated with relaxation, sleep, empathy. So somebody that's really high-strung, anxious, maybe you want to pulse your laser between a half hertz or 3 hertz. Theta waves, 3 to 8, associated with creativity, imagination. Alpha waves associated with the default mode network. This is the mode network that allows us to be present. It actually is one of the mode networks that are shown that learning or plasticity occurs the best in. Also with alertness and calmness. Beta waves associated with focus, judgment, decision-making, problem-solving. We all see patients that have some struggles in that area, so maybe that's something we want to focus on. And gamma waves, which are associated with love, consciousness, and also gamma waves have actually been shown to turn on glial cells, which is kind of neat too, because you can have an immunological influence using light waves. Okay, so dosimetry, let's work backwards. So let's just say our target, for the sake of this example, is the right dorsolateral prefrontal cortex. Not for any reason, and as we go through this, what I don't want you to do is say, okay, Dr. A said the right dorsolateral prefrontal cortex needs 264 joules, so that's what I'm going to set my device at. This is a process by which we can break down how to calculate your dosage so you determine it. So the wavelength of 808 we see is greater or more effective than other wavelengths, so let's just say that's the wavelength that we're going to use. We know that the frontal bone transmits about 2% of the activity. We need to consider probably about 20% impedance for hair follicles, for tissue melanin, things like that, and especially if somebody's not shaved. And our target dosage that we said is at max 6 joules per centimeter squared, but we're going to want to shoot for 2.2. So we've got a math equation, 2.2 joules per centimeter squared. That's our target tissue fluence. So we're going to say if only 2% of the dose gets through, we're going to have to multiply that times 50, right? And that equals 110 joules per centimeter squared. We're going to give it an additional 20% for some interference with follicles and hair. So our estimated dosage is 132 joules per centimeter squared. Now we say our surface area that we're going to treat is 2 centimeters squared. Maybe that's how big the aperture is of your light source. So what does that mean? If the dose that we had is 132 per 1 centimeter squared and we need to treat 2, what do we need to do to our dose? I just gave you the answer, right? We've got to double it. So 264 joules, that's what we want our light source to put out. Okay, so to target the dorsolateral prefrontal cortex, we need 264 joules. It needed to be spread over roughly a 2 centimeter squared area and need the wavelength to be near infrared or infrared, so greater than 750 nanometers. So let's talk about an instrument. Let's just say our sample instrument, no brands associated, is 808 at 1 watt per centimeter squared. It's pulsed at 20 hertz, 50% duty cycle, which means that our effective output is 500 milliwatts per centimeter squared per second. Our aperture is 2 centimeters squared at the skin surface. So pretty good, easy statistics. But what if we needed to hit 4 centimeters squared? What can we do? There's 2 options, right? We could either move our light source or what else? Pull it away from the skin, right? Because the light projection is conical. So as you pull it farther away, the source is going to get bigger. But many types of non-coherent light follows the inverse square law of like X-ray. So for every time you double your distance, you have to double your power by 4 in order to get the same amount of energy hitting your source. So just something that you need to take into consideration. But that also depends on a lot of different things, your spectral bandwidth, the laser lens focus, things you're going to want to ask the person you're purchasing a device from. So now we need to calculate time. So 264 joules is what we want. So looking at the bottom of the screen, joules is watts times seconds. So 264 joules times our effective dose, which is 500 milliwatts, times 1,000 to get it from milliwatts to watts, means we need 528 seconds of stimulation, which is about 8.8 minutes. Okay, so that's where you need to be in order to deliver the appropriate dose that's going to reach your target tissue. Do you see how we worked at the target tissue and went back? We just didn't go to a setting in our device that says brain, because that's not going to be the best thing for your patient. Okay? Side effects. So this was pretty neat. Paper published, oh man, I'm sorry, I took the date off of there, but it was a recent paper. So adverse neurological effect were seen in those with over 750 milliwatts per centimeter squared. So which is about 100-fold of the optimal dose. And also, it was in the continuous waveform mode. In the pulse mode, there was much less heating and no tissue damage there. So realistically, there is very little risk, or there pretty much are no real published side effects of using photobiomodulation as long as you have the right settings. So when what the research is pretty well conclusive of, a less than optimal choice of parameters will reduce and end up in reduced effectiveness. But simply an inappropriate choice of light source and dosage is usually what causes the side effects. Now, taking a couple seconds, just coming back where we started, how can photobiomodulation help TBI recovery? Well, when we look at the screen here, what we end up seeing is that down in this area, during a concussion, we start looking at injury to the mitochondria, decreased ATP production, we have decreased energy synthesis. So right at the acute phase of the concussion, laser can necessarily help the chemical cascade associated with that, but it can also help with the inflammation and also can help with the synaptogenesis. So in conclusion, photobiomodulation for brain disorders will become one of the most important medical applications in light therapy in the coming years, looking at the brain influence on light. Dosimetry remains the most difficult and controversial element of photobiomodulation. However, transcranial photobiomodulation may be able to mitigate cellular processes involved with chronic and acute concussion symptoms. So thank you so much for all of your attention.